still encouraging us, if there's a seat available in front of you, kindly move forward as we get ready to start. Try 2. All right. Good morning once again, colleagues, and it is my pleasure to welcome you to the fourth and the last in the series of anniversary lectures that are commemorating our 45th anniversary as an institute. The theme is the 45 years of impactful research for sustainable global health. Over the last month, we have had talks outlining the impact of Noguchi's work with respect to rotavirus vaccines and HIV and malaria. And today is going to be one with a slightly different focus, because we'll have someone coming from outside who we work with to talk to us. So in order to make progress, I'd like to invite Reverend Mrs. Eunice Ampim Danso to commit the program into the Lord's care. Let's welcome her, please.
Thank you very much. Good morning, everyone. Thank you for having me. Shall we please bow our heads and pray? Our Heavenly Father, we are grateful this morning once again. You started this lecture series with us from day one, and you have been faithful through it all. Today, Noguchi is gathered once again, and you know we don't start, Father, without you. That is why this morning we are saying we thank you. Thank you for how far you have brought us as far as the lecture series is concerned. Thank you for your awesome presence and your awesome touch, O Lord. We thank you for the gift of life. We thank you for the gift of the day. We thank you, Father, for good weather. And we thank you that, Father, indeed we are gathered once again, Father, to listen to all that you have prepared for us today. Right now, even as we start, O Lord, let your awesome presence take preeminence over this place, even in Jesus' name. We place the entire program into your hand, and we ask that you will order it according to your will, even in the name of Jesus. I commit the presenter into your care. Let your awesome presence and your outstretched right hand be upon him, O Lord. I pray that even as is delivered message, let us have an insight into surveillance, Father, system and emergency response in the name of Jesus. At the end of this lecture series, we shall receive new ideas for a better surveillance evaluations and response, Father, system even in Ghana, in Jesus' mighty name. Let your name be praised. In Jesus' name we pray with thanksgiving. Amen.
Thank you very much. Thank you very much. So we'd like to go on with our program. Protocol demands that we recognize the head of this institution under whose auspices the lecture series is being organized. And so I'd like to call upon Professor Michael Ofori, who is the acting director, to give a few remarks. Prof. Ofori, let's welcome him, please.
Good morning to you all. On behalf of the director, I welcome you to this morning's seminar. She will be joined us by maybe with Lane, so he asked me to stand in for her so that we can start before she comes. But as we have seen over the past 1 month, the institute is 45 years. And at 45, we want to demonstrate what we have done, where we started from, where we are, and the way forward for the future. So over the past 1 month, this month, the whole month, we earmark it to celebrate the things that we are doing. We have listened to very top-notch talks from our various top-notch scientists from the Institute who have taken us through a series of things that we think we have done very well. But you all agree with me that we can always associate the Institute to excellence. Today, as Dr. Dennis said, it is the last of the series of the talks that we are having this morning. And there's a very important aspect of our work we do in the Institute. It's also to support the Ministry of Health in special diagnostic areas. And over the years, you all agree with me that we have done that excellently as an institute. And you can always be associated with what we do in support of the ministry. And in so doing, this last lecture, we decided to invite a very important person who has been very supportive to the Institute. Has cooperated with us, his term as the director, but I won't mention him. I'll leave that one for the chair to introduce the presenter to us. But he has been very, very, very supportive to the Institute over the years. And so we are very happy to have him here to tell us what we have been doing with them over the years, what he think we want us to go for the years to come as the director in the ministry, all in support of what? Promoting good health for the people of Ghana. And therefore, the director is very happy to actually have him here. He wanted to, I'm sure he will come before he finishes the presentation. And then so we are so happy to have him. And also to all of you, especially the young ones. These talks tells you where we are, how we started, and where we are actually getting to for the years to come. So listen attentively, and I'm sure you have picked something from it. We'll climax our anniversary next week. And we have earmarked the 7th of November, which is next week, Thursday, as the day that we'll do this, our final celebration. Of course, we are inviting people from outside for a symposium, and then we'll listen to very high scientists, high caliber scientists talking to us about the areas that we think we should concentrate in the years ahead. So I want each and every one of you to prepare yourself for next week. Plan very well so that you'll be able to join us to celebrate the day. And I wish all of us a very 45th anniversary. So I would like to call on the MC to introduce our chair for this morning, who will then introduce our speaker to us. So, Dr. Dennis.
Thank you very much. A warm round of applause for our acting director, please. Thank you. So now it is my duty and pleasure to introduce to us a chair for today's lecture. I will do my best to keep it simple and straight because she's quite accomplished. She's an associate professor of epidemiology, and she's the former head of department of the epidemiology department here at Noguchi. She has expertise in parasitology, immunology, and molecular epidemiology of communicable and non-communicable diseases. She is a Commonwealth scholar, a Mujeres por Africa Science by Women Fellow, and a proud alumnus of the London School of Hygiene and Tropical Medicine in the UK. She has been working on malaria for the past 26 years, and specifically on anti-malarial drug resistance. She has been part of the malaria group here at Noguchi, working in collaboration with the National Malaria Elimination Program for the therapeutic efficacy studies in Ghana since 1998. That's quite a while back ago. Her work for the therapeutic efficacy studies helped to change anti-malarial drug treatment policy in 2005 from the use of chloroquine to artemisinin-based combination therapy for uncomplicated malaria. And she has been in charge of the molecular aspect of the anti-malarial drug resistance all these years. So apart from malaria, she is also investigating the molecular epidemiology of other parasitic infections and cardiovascular diseases. A publication from her collaboration with scientists from the malaria branch at the Division of Parasitic Diseases and Malaria Centers for Global Health of the CDC in the US got a nomination for the prestigious Charles Shepard Award for Laboratory Science in 2017. She has grants for malaria and other parasitic infections research and has authored over 70 publications and has mentored and still continues to mentor several postgraduate students and postdoctoral fellows. She is a member of the faculty of WACPIP here at the University of Ghana, the Pan-African Vivax and Ovale Network, PAVON, and the Malaria Intervention and Resistance Network of the National Malaria Elimination Program. She has several professional memberships, which include American Society for Tropical Medicine and Hygiene, the British Society for Parasitology, and the Worldwide Anti-Malaria Resistance Network, among others. And she is a reviewer for several high-level peer-reviewed journals, such as the Lancet Microbe, Lancet Global Health, Lancet Infectious Diseases, and quite a few others. She's also a member of the NORMA Grant Review Committee for La Caixa and Volkswagen Stiftung, that is VW, and Wellcome Trust. And she has served on several boards and committees of the University of Ghana and this institute. I think by now we can all guess who she is. And most importantly, she wants it to be acknowledged that she was mentored by Professor Michael David Wilson. So please join me in welcoming forward our chair for today, Professor Nancy Duakwashi. You can do it better, please.
Right, thank you so much. Thank you so much for this introduction. And like he said, with the last sentence, I'm a mentor or a mentee of Professor Michael David Wilson. So this morning, before I go on, I've sought permission from the organizers to celebrate the late Professor Michael David Wilson. Yes, this is the late Mike Wilson. This is the smile that he always wore on his face. I never saw him once angry. And I remember being sent to his lab in 1996 as an intern. And he is so much into helping mere undergraduates become great people. And that is why today I celebrate him. So he was a professor in pastology and the former deputy director of the Noguchi Memorial Institute for Medical Research. And he joined this university in 1994. He was promoted to senior research fellow in April 1996 and went on to become associate professor in February 2000 and professor in 2006. He retired officially on 31st July 2011 and had to work 9 more years on post-retirement contracts. Some of the important roles that he did. When I came to his lab, he was so much into onchocerciasis, and he was part of the group that helped with the disease in Guinea. He's one of the main people that started very, very good institutions that has helped with our research over the years, like the NMIMR Institutional Review Board, and then the Office of Research Support. This he did with others like Professor Kwejo Kram when they got their big NIH grant and they needed all these institutions set up for the work to be done effectively. He's also one of the main people that set up the West African Center for Integrated Parasite Control, WASIPAC. And then he was so much influential in getting the Prince, our lead bin Talal building for clinical trials. He helped with the Yale NMIMR Student Exchange, Lymphatic Filariasis Support Center for Africa, the Bill and Melinda Gates Foundation postdoc project, the WACBIB, and the Advanced Research Laboratory. You can see that he's done so much, but these are just institutions. But what he did that is splendid to talk about is his investment in people. He loved people. He loved to see people excel. And he will ensure that you will excel. If you are dull, you will become somebody. So I was just looking out for something that would really let you know who he is with my subsequent slides. And then I saw this kind of quotation from the Vice President of US. It says, the real strength of a leader is who you lift up and not who you beat down. And that was Prof. Wilson. I was reading through some of the tributes that people have written that I had to collect. And one of the phrases that I remember, the person says that he's not a typical African leader. because he's interested in going up with everyone, and he ensured. So these are some of the people that he has influenced. These will tell you who he was. When you come in as a mere intern, he's thinking about what your research project is going to be about for your undergraduate studies. When it's done and you are there, he will try and get you to be part of his national service personnel that he would get for that year. And then when you are finished with service, he would find you scholarship for you to do your master's. And that is how my story has been with him. So you can see that he had one that is the vice chancellor of the University of Cape Coast. He was in the lab with us. Then Professor Michael Achunibuana is the director of CSIR Water Research Institute. Then the Episcopal sister, that is the bishop rank for ladies at the Lighthouse Chapel. And then we all know Prof. Anita Gansa is the head of the Department of Epidemiology, Pastology. Then Professor Niels Ben Kwashi, and then Nancy Kwashi, then J. John D'Souza. J. John D'Souza is the man after Prof. Wilson's own heart. That is what is in the Lydia. So just count the pages of the people that he has influenced and just see where they are. That is the second slide. A list of doctors, some scientists. He would, depending on what the needs are, he could turn a scientist into a lawyer so that the person can be on the IRB. Depending on whether he needs an ethician, he would just get one from his normal students and say, you are going to go to the law school and you would have to go to Yale and learn, and this you would have to go to and become a good RDO to manage the office of it. So that is him. That is him. He could turn anybody into what he thinks you would be relevant for. So these are some of the names. So these names that I'm projecting today are those that I could just get from off my mind as I sit and I look through. But I know there are so many of you that your names will not be here. But I need you to give me your names when you are done, because we have a special thing to do for him. Then the list goes on and on. So we have Nanoye Ekufo, who came in as a secretary to the director, and then she's ended up becoming the distinguished faculty member of the Society for Research Administrators International. Jiwalna, Irene, and all the people that I've listed here. And then his last PhD student that completed before he passed is Dr. Kwesi Tando. So that was his baby before he passed. The list goes on. So we have these are some of the people that are still doing their masters or doing their PhD. So that is the list. So I still have question marks for other names. So if your name did not appear here, it doesn't mean that I did not know. But all the people that I've shown here are those that influence their lives immensely. So ask the one next to you, how long is your list? Ask the one next to you that, how long is your list? Yes. So we go on. So all we want to say this morning is just a big thank you to Professor Wilson for the lives that he has impacted. So we are joining as a group of all the ones that he has influenced. And today we are not crying, but we are celebrating him, because he lives in all of us. In all the names that you saw, he lives in that. So we are saying, Monio, Yedas. Rest in peace, Prof. Wilson. And his nickname is Mickey Mo. Put your hands together, please. And I'm so happy that for him. I know that I did that for him. So my last slide of him is his funeral invitation, which is coming off in the next month. So thank you, organizers, for the opportunity to celebrate this gentleman. So now I'll go on with my work for this morning as the chair for today's seminar or talk. So for several weeks, we have been listening to great talks by renowned scientists from this institution. I would say that they came and they really bragged about what the institute has done for this nation and the global world. But today, it's good when people tell you what you have done than what you tell others what you have done. So today we have somebody coming from the Ghana Health Service to tell us what Noguchi has done for this nation. So he'll be talking on the topic, the impact of NMIMR on the GHS disease surveillance and emergency response system. So let me just give you a brief on this gentleman. Dr. Franklin Asiedu-Bekoe is a medical doctor and a public health consultant with specialization in applied epidemiology and disease control. He has been a public health practitioner for the past 22 years with competencies in surveillance, field investigations, research, data management, scientific communication and teaching. He has worked in the international, national, regional, and district levels. Dr. Asiedu-Bekoe is a fellow of the Ghana College of Physicians and Surgeons at the Faculty of Public Health. He was a consultant for World Health Organization and Centers for Disease Control and Prevention, CDC, on the global program for the eradication of polio in Afghanistan in 2010. He's a facilitator at the Ghana College of Physicians at the Faculty of Public Health. Yes, he has been the lead investigator in several outbreaks, including cholera, pandemic, influenza, H1N1, yellow fever, Lassa fever, and meningitis. He was a member of the team that investigated the first Lassa fever cases in Ghana in 2011. Ghana was certified Guinea-worm-free in January 2015 during his tenure as program manager. He was the Deputy Director, Public Health and Head of Surveillance Department of the Ghana Health Service. He was the subject lead on real-time surveillance and workforce development for national internal assessment on public health emergency preparedness, and has been a subject matter expert for joint external evaluation missions in Lesotho and Swaziland in 2017 and 2018, being the technical area leads in real-time surveillance, workforce development, reporting, and chemical events. He's a member of the experts review team for the 3rd edition Integrated Disease Surveillance and Response technical guidelines and training modules. He was the lead for the adaptation of the Ghana 3rd edition IDSR. He is the leader of the surveillance thematic area for the Ghana COVID-19 response and co-chair of the Ghana One Health platform. Is the convener of the National Public Health Emergency Operations Center. Is now the Director of Public Health, Ghana Health Service. He was given the Order of Volta, Companion Division in 2023 for his meritorious work towards the COVID-19 response as a National Task Office member. Please put your hands together as we welcome Dr. Franklin Asiedu-Bekoe.
Thank you very much, Madam Prof. So my topic was the impact of Noguchi on the GHS disease surveillance and surveillance response system. So I decided to change the font size of some of the words here because they have different meanings. So, you see, this one is big. Disease surveillance is big. This one, I decided not to touch it. And then this is also big. And then this is for you. So, I remember calling one, and I said, this one is a fixed match. Fixed match. So, the reason why I did not make this bold is that it gives the impression that there's something called Ghana Health Service disease surveillance. No, it's Ghana. There's no other disease surveillance system that exists. So if you give GHS disease surveillance, then do you have Kolebu disease surveillance? It's confusing. So that's how I decided to make sure that I bolden some of the words to give a clear perspective. So my name is Franklin Asiedu-Bekoe. In some time back, I used to call myself Asiedu-Bekoe. But now I'm Franklin Asiedu-Bekoe. Because there's a colleague who is another guy who is Frank Asiedu-Bekoe. He's a politician. So one guy told me, I have stopped the medicine, I'm not doing politics. So now my name is Franklin Asiedu-Bekoe. It's a compound name. Normally I stress on that. Okay. So I remember asking for Odum, the audience. I want to get the idea of the audience. Because my presentation has different perspectives. Some for you to understand the disease surveillance system that you have in the country, to understand the response system. They have a lot of meanings. Because if you are not very clear, you are not sure what is going on. So this is my overview. I'll just have a look at an outbreak. I mean, I am biased towards surveillance, and I normally talk about it. Because I say that whatever plan you have, if you have this thing, you can mess it up. So like now we are getting cholera. So today I don't want to shake people. Ghana, everybody wants to shake you. You know, Ghana, we like shaking. So then I will talk about what emergency response system do you have in Ghana. And it's good that we all understand. So this is my presentation. It's let you understand the Ghana. And then what surveillance system you have, because there's an interplay between the service and then Noguchi. So I see for Vodum and Kofi Bonnie and the directors were asking for money. I said me too. I said also we're also giving professors here. Then I'll talk about a few outbreaks you have reported over the past maybe 5 years, and then go into details about the support that we are getting for the Gucci, and then I have a slide about the outlook of laboratory networks in Ghana, and then I'll conclude. So basically, this is my presentation, and so I'm hoping this is my slide. That because my first word here, I underlined outbreak. Just somewhere last year. Okay. So somewhere last year, I had a call from a colleague that why have I declared the Lassa fever outbreak over? I said I don't have the capacity to declare an outbreak over. Declaring an outbreak is legal and political. You can have technical meanings to it. The Public Health Act says that it's the Minister of Health who declares an outbreak. So they are told the media persons go and change the wording. The person who put it there because it was like a caption. Ghana Health Service declares Lassa fever outbreak over, and he put my picture there. And I say, I don't want problem. Go and change it because I cannot declare an outbreak. So one thing I'm saying is that outbreaks are becoming very, very common in Ghana. And I think that I need to state that Noguchi is one big player that is helping us do that. Because you can die and nobody will know what killed you. Maybe it could be witchcraft. Yes, if you don't know what killed you, something should kill you. And to me, the essence of public health is about diagnosis. So if you don't know what killed you, we'll give you something. So outbreaks are getting common, and they require prompt measures. And I think I'm supposed to have a meeting today. I have to skip it for MPOX. We have this Africa meetings that we do, and I think 2 weeks ago or 3 weeks ago, the capacity to confer MPOX was only just 30%. So, but thankfully Ghana, we have that capacity. So let's clap for Noguchi. and it's big that you can confirm, because the response is dependent on the causative organism. So, and I think I've said it here. But one thing is that when talking about outbreaks, it could be a single case leading to an outbreak, which is common, like cholera or yellow fever or MVD, Marburg, or EVD. But then there are some instances that you need to have several cases. So the underlying word is about threshold. So for meningitis, and at times the media people like to worry me a lot. When we are in the season, they get one case in Accra, they say it's an outbreak. I say, what is the threshold? So clearly for outbreaks, it's about a threshold. And then as I'm saying that they occur due to several factors. So this is a slide, and I'm saying that there are a lot of the risk factors that still persist. So the Wuchi will get a lot of work to do. For the risk factors are there, and then several factors drive outbreaks, and they vary across populations and over time. So there could be human health and non-health factors. But the issue is that you need to have an increase in susceptible population. So we have been getting occasional yellow fever outbreaks, and for Bonnie is happy. Because you have these nomads who come across the country from the Sahel region. They are not vaccinated. They enter through the savannah region, and then they get bitten, and they get the infection, and they share it among the population there. So you realize there's an outbreak. So when you have a susceptible population, you are likely to get an outbreak. So you realize that the past 2 years, Ghana has had a number of measles outbreaks, because our measles coverages came down. So you have a lot of children who are not immunized, and then you are prone to get outbreaks. So you need to have that population. And then poor water conditions. As I was coming, I sat down a long time in my car, because we have this outbreak of cholera in Adan, east and west. And then this is a situation whereby there's no potable water. There's no source of toilet facility. So we are advising them to not defecate in the open. Where should they defecate? Prof, you are welcome. I'm looking at Prof. Koram. So there are a lot of predisposing factors why you're going to get outbreaks. And then we have the overcrowding. So one I get scared of is where you have a pathogen being introduced in overcrowded areas. You have a lot of urban slums. And then you have a lot of environmental factors, vectors. In this era of climate change, you're going to have increasing numbers of vectors in their population, like this dengue outbreak. Why did we get it? So the climate factors and the environmental degradation predisposes us to have a lot of outbreaks. So those are the issues we need. So clearly, there are a lot of factors why we are going to get outbreaks. So this is my slide, and it's about. So this one is where I work. It's nice. So that building inside is the EOC. But let me take my time and explain the emergency setup we have in Ghana. So I'm trying to start from the top. So at the top, which is not very pronounced, is what they call the Inter-Ministerial Coordinating Committee. That one is where the ministers operate. So they set the agenda for outbreaks. But normally we don't get big outbreaks, so they don't work. They come into motion when there are big things, like when COVID came. Then you realize that you have interministerial. So all ministries that directly or indirectly have to do with health, they come into motion. And then it's chaired by the president. But if it's not that big, it will be chaired by the Minister of Health or the Interior Minister. But for a big player like COVID, the president, and then you have the vice president as a deputy chair. So that's the biggest coordinating point in the country. So normally you don't hear of them turning to the outbreak. Like this cholera, I don't think it will get to that side. We'll play it among ourselves. Then you have the National Technical Coordinating Committee. Here are more of technocrats. So they actually kind of take information from the committee and try and make sense out of it. And this committee is normally chaired by the Minister of Health. So when we had the COVID at the early stages, we were meeting at the Minister of Health, and most of that was chaired by the Minister of Health. And just I will say that after EVD, this new idea of EOCs came about. So the emergency operation centers. So this is a coordination point, purely technical, and working on thematic pillars. So you have surveillance, case management, IPC, risk communication. So they are actually the core technical people who analyze the outbreak and give recommendations. And then they have this rapid response team that go to motion. So that is the structure we have in a country called Ghana. And then when we go to the region, and let me say that when it comes to outbreak, the person in charge is the political head. And let me go back, 2008, I was in a district, and we had this very bad meningitis outbreak. And the DC was becoming like this. And well, you know, we were going to vote. So I told the DC, that they call chief, say, what's about? When the people are dying, because the DC can lose his job. If people are dying and you're not doing something about it. So when I told him that people vote, you have to sit up. So outbreaks are supposed to be managed by the political heads. So if you go to the regions, we have what they call the Public Health Emergency Management Committees, and it's chaired by the regional minister. So like now for this cholera, it's the regional minister who is supposed to see that we get water to our dam. So those are the big players, and then we have the response teams. So those are the technical guys with that thematic areas. This same structure exists in the district. So at the district chief executive is the lead of this management committee, and they are in charge of coordination. They are in charge of mobilizing resources, and they set the agenda for the response. So this is the setup we have in Ghana when you talk about emergency response. So for emergency response, there are a lot of thematic areas, but I want to pick a few because of this lecture. So we have the cross-border from outside to the inside. So if you want to look at, let's say, Mpox will come from the outside. So what system do you have in place to ward it off? So the first pillar is point of entry or cross-border. And then it gets to the country, and then you have the surveillance system in place. And then you need to confirm. And then you need to manage the cases. And you need to prevent infection. And then you need to communicate. Finance, one big challenge we have for public health emergency is finance. And then logistics. So these are the pillars for emergency response that exist globally. But I'm focusing on these two pillars for this lecture. So Ghana uses the IDSR. It is the strategy adopted by WHO, and it's very, very cost effective. So what it does is that it improves public health surveillance for priority conditions. So I'll give you a list of what are the priority conditions, and then this works at all levels of the system. There are instances that you have from these partners. You want to bring the ideas. I say no. We're using IDSR. is very cost effective and integrated. So this is not my slide, but I will talk about it. There's a slide that I put there. I say it's a network of the health facilities, the laboratories, and then the persons within. So what is happening is that you have a lot of facilities at the all levels, and then you have designated labs who can make sure that this system works, and then you end up at a reporting site for action. So that is the disease surveillance system we are talking about, and then it involves detection, sample collection, laboratory testing and confirmation, and then reporting and analysis and interpretation. So these are what we call the core functions of surveillance. And I like the first part, detect. You know, when you go to consulting room and they say you have diarrhea and you are vomiting, you can have a doctor who will say that what you have is gastroenteritis, because he doesn't want to say cholera. Cholera changes the response, becomes a public health issue. So the doctor is the one who sets the agenda. So if he says that, if you look at this outbreak, something like that is happening. So they are getting reasonable number of diarrhea cases. It was gastroenteritis. Some day they take samples negative, but cholera does not come in. So if you do not situate the diagnosis well, the response is different. And it's very, very important. We had some time ago a suspected Lassa, which was not a Lassa case. It was more of an upper GI bleeding. We say it's Lassa. We started giving some wild tablets. The person vomited and maybe died. So what I'm saying is that surveillance starts with a clinician. So if the clinician does not think about it, you sitting in the lab, what are you going to do? He says the thing is not cholera. You won't bring any sample. So that's the way the surveillance system works. And it's at all levels about networks. I'm hoping my slide is not very much different from what I want to do. But then, so there are some priority epidemiological diseases in Ghana. So we have about 14 of them. We have the acute hemorrhagic fever syndrome. So we have the Ebola, and normally when we send samples, we want for Bonnie to rule out all of these things. And then we have anthrax, and we have meningitis. And I like this meningitis because if you do not get it right, your response is different. Then we have cholera, you have COVID-19, dengue, then diarrhea of blood, foodborne illness, flu-like illness, mpox, rabies, SARS, plague, and yellow. So this is what our surveillance is trying to look in terms of priority. And I want to introduce you some two terms here. There's one which is called the IDSR, the one I talked about. It's a strategy, but I'll say that one is merely a strategy which is inborn or in country. But that strategy can also help you prevent the transmission of a disease to the outside world. So that one, as far as it becomes an international condition, if you are looking at this as an IHR. But then there are three cardinal things that applies to all. It's about detection, it's about confirmation, it's about report and timely response. So these two strategies have the same kind of attributes that you need to use. But when you have a health event in a country, WHO requires that member states do an assessment. An assessment is done using what they call the decision instrument Annex 2. So this instrument will give you an idea of what you need to do. It wants to lead you to what they call notification. It's like you have to officially inform WHO that I have this condition. So it's not that you are saying I will talk about this or not. You need to notify. So if you look at this first box, if you have any of these conditions, you need to notify WHO. And somehow all of these conditions can only be done in Noguchi. So if you happen to get any wild polio virus, at times I've been fighting for polio. When you are there thinking about yourself, they bring something else. So if you have wild polio, you need to automatically notify Noguchi. If you have smallpox, you need to notify Noguchi. You have any human influenza caused by any virus, like now we have this H9N2, Noguchi, SARS. So this is the first group. So here, you don't have the option. There's a second group. If you have any of these conditions, then you need to apply a set of questions to determine whether you should notify or not. So let's say if you have cholera, like we have now, there are sort of questions that you need to ask and answer. The answers will tell you whether you should notify WHO or not. So you have 2 or more yes. Is that sound like yeses? Oh. You have 2 or more yes. You have something like that. Yes, so you have 2 or more, you need to notify WHO. So let's say you have cholera. The question is, does it have serious repercussions for public health? And so here you're looking at a few things. One, you look at the disease burden, numbers. Look at fatality. And then you want to see whether there's a capacity to investigate. So for cholera now, there's no any big deal about. You're welcome. By 9 tag boss. So here you cannot cholera. Everybody can diagnose. So let's say if you get 2 cases of cholera in Ghana, it's no. You understand? But then assuming you get about 1,000 cases and about 100 dead, at that instant, it moves to be a yes. So in that case, the first one was maybe 2 cases. I remember just last month we had 2 cases in Kitu South. 2 cases of cholera. There's no news. We don't need to talk about this. But then another issue is it unusual or unexpected? So do you expect to get cases of Marburg in Ghana? No. So if you get one, it's unexpected. So it becomes a yes. The another issue is the risk of international spread. If you look at this current cholera outbreak that we have, so now along the west coast of West Africa, almost every country has cholera. So if you look at some of the outbreaks, there are people fishermen who went to Togo to fish, they come back and they bring the thing. So the risk of international spread exists. So in that case it becomes a yes. And then does it affect travel or traffic restrictions? And this is what was making the COVID response very difficult. So when you get to COVID, even this Mpox, they started putting some travel ban on Congo DR. So the idea is that if you have any condition, you need to be able to answer these questions, and then you need to notify WHO. So every country has what we call the IH focal point. So it's a communication entity in the country that communicates with WHO formally when there's an outbreak. So Ghana, the communication point is the disease surveillance department, which is the IHR. So IHR point is not a human being, it's an institution. And they coordinate WHO with the contact points. So so for the year 2024, we've done a few notifications. So the current, we have got 2 outbreaks. We had the first cholera outbreak in the same Adan East. It was declared over. And then we have a new one. Normally, if you're the last reported case, you go 2 incubation periods out of it without any case, you say your outbreak is over. So we had one and we reported to WHO. Then we have also notified them of these cases, the dengue, the one that happened mainly in eastern region and then central region. And they have this first human case of influenza, H9N2, and then the cholera. So normally, if you notify WHO, the report will go to the DG of WHO, And they will now have to sit down and make a determination that does that event constitute fake. A fake is a public health emergency of international concern. Normally, you can have a condition that you call a national public health emergency of national concern. Like recently, we have this circulatory vaccine-derived poliovirus. So it's of a national concern. It's not international. But this one, the determination is made by the DG. So he will refer the event to the executive committee, and they will now look at it under a criteria and say that this condition can affect a lot of continents. So what they do is that they want to ask themselves, is it an extraordinary event that may constitute a public health risk to other countries through spread that may require international response? So if you say yes, yes, then they will declare it as a fake. And over the past, I'll say 15 years, this number of conditions have been declared as fake. So 2009, they declared pandemic influenza 2009 as a fake. Then EVD was declared as a fake. Polio as a fake in 2014. Zika was declared as a fake in 2016. Then Ebola in Congo DR. Then the COVID-19. Then the Mpox was declared in 2022. It went away, and this year has come back. So these are the fakes that we have had over the period. And normally, before you can say it's no more a fake, the DG will also refer it to a review committee, and they look at the circumstances and say that we think we are out of the woods yet. The fake is over. So now, COVID-19 is not being declared really that much of an issue. But then, I want to talk about public health is about diagnosis. So if you look at the Ghana now we are in, for the level of outbreaks I'm talking about, we are talking about 3 big labs. So the main lab is the Gucci, where we are. And then we have other growing labs. So we have cases here, and they have our reference lab. So for purpose of surveillance, these are the labs of focus. But mainly it's reference lab and the Gucci. The Gucci is the Obodo. Okay. So we also need to look at the priority disease conditions. Where do they get them tested? So if you look at AFP, it's only Noguchi. You look at the acute hemorrhagic fevers, it's Noguchi. Cholera is done at the reference lab, the zonal labs, and the other regional labs. COVID-19, it was multiple. So when there was money, you had a lot of private labs coming in. Now they finished, they stopped. The environmental polio was Noguchi. Flu, Noguchi. Measles, reference lab. Meningitis, a lot of the reference labs. Mpox is reference lab, and then Noguchi. And then yellow fever, reference lab. So basically, this is what the issue is, that if you are not a designated lab, you do the test for what? Because the WHO know you can't make money out of it. So you need to see, if we pick a sample, where are you taking it to? Because you need to be accredited lab for relevance. And I'm now going to talk about a few outbreaks we had in Ghana. So Ghana has recorded several outbreaks over the period. So we had COVID-19, the flu, H1N1, and then yellow fever. And then we have also had cholera, Lassa fever, dengue, Marburg, and then a number of foodborne outbreaks who have also been recorded. So I'm trying to give an idea of the kind of outbreak we've had over the period. So it's not every outbreak that comes to the Gucci. Some are done at the regional level, some are done at our reference lab. So this slide is to give meaning to, over the period of like 5 years, we have so many outbreaks. Cholera, circulatory vaccine virus, cholera, COVID-19, yellow fever, Marburg, all of these things. And you need to respond to all of these things in a country called Ghana. And you can do it when it's integrated. And one of the successes of Ghana is like our system is integrated. We have very little of vertical programs running. So you can see like countries like Nigeria, they have a very solid polio program, very rich. You come to yellow fever, they are struggling. If it comes to maybe cholera, they are struggling. So our system is integrated. It is good for the way we operate. It's good for our economy. It's good for our system. So I'm trying to look at what the years, what kind of outbreaks have we recorded. So we've recorded about 3 outbreaks of cholera, 2018, 2019, 2024, SARS-CoV-2, 2020 still up to date. Then circulating vaccine derived, we still have one 2024, and then dengue, 2023, 2024, I think 2020, no, 2022, 2023, 2024, then flu, all of this, Lassa, 2023, Marburg, 2022, Neisseria meningitis, 2020, and then Mpox. But we also have 2024, then yellow fever. So these are some of the outbreaks that we have recorded over in recent times. And this is where they have been distributed across the country. And I think it's good when you have a very geographically represented system in the country, so you can detect the cases as they occur. So this is our COVID-19, which somehow was all over the regions, though the epicenters were Greater Accra and Ashanti region. So this is the Mpox. I'm talking about the old one in 2022, 2023. That was also mainly focused in Greater Accra. You see, one of the things is that the Mpox outbreak that we had in 2022, we were not able to establish the critical at-risk groups. Other people, men with sex, but Ghana, we couldn't establish that. Men are having sex with men. Other countries, they have that. But Ghana, our outbreaks was not, we couldn't identify any particular group. So this is the Marburg virus disease. And let me tell you something about this Marburg virus disease. It was not that the people suspected Marburg. And it was similar to the first Lassa case in Ghana. I mean, that time I was in Ashanti region. Because, so you go to the people see, as a clinician, you see somebody coming in with upper GI bleeding. So that's his diagnosis, upper GI bleeding. Then the next day, somebody comes also a similar complaint. They say, could they be related? And that's the time that they try to link up. So for the first one, you didn't suspect. But when you have 2 conditions at a similar point in time, then you think that let's suspect it. So that's how come they did it. And then we were able to get it early. What is good for surveillance is about timely response, timeliness. I normally say that somewhere 2015, once our outbreak got to us with the minister. Minister of Health was now telling us there's an outbreak. So I was there, and at that time, the Dr. called there, my boss. He called me, Kofi. Then the course will Cape Coast. Then the course. Like, what is happening in Cape Coast? I said, I don't know. Apparently, the minister had called him. That what is happening in Cape Coast? Say he doesn't know. So he thinks that the head of surveillance should know. I also didn't know. Apparently, they had an outbreak. And they are not telling anybody. They say they are managing it. So that's one challenge that we have. And I remember communicating once to a team from Canada, and they were trying to tell me that Malawi had a cholera outbreak for about a year. Likewise, Zimbabwe. Asked me what is the issue. And I said that, to me, what I push is that surveillance is about detecting and reporting. Some people think that when you detect, you shouldn't report, because you'll be found as a bad guy. So by the time they report, the case would have been big and large. And that's one challenge that we have had. And that concept was in the past. I remember those days when I was in the district. It's like, hey, make sure you don't get any disease. Oh. So if you get a disease, how are you going to report? And so if that detection and reporting is not efficient, by the time you realize you have an undermined outbreak, it takes so long a time to address it. And I think that I also need to state that I saw this earlier on that when, like the Lassa fever case, it was actually suspected by a nurse, not even a doctor. So at that time, we had communicated to them that any bleeding with a fever, think about something else. So they calling me, hey doctor, in that case, so I'm not calling Accra. That we have this, say, try and get some samples. So if the clinician hasn't got a high index of suspicion, you will never be able to get cases early. So this is also measles. It used to be very low on the radar, but for the past two years, the cases are going up somehow because of the reduced coverages that we have had. And then you realize that the immunity is very low. So it's a challenge for now. So if you look at the slide, you see it's going up. Likewise, the confirmed cases. So how do we manage the outbreaks? So the outbreaks are managed, mainly the center is a district. For Ghana health system, the fulcrum is a district. That's the center. That's why now before we become a district director, we do exams. Yeah, you do exams. Some people call me that director. I say fine. If you give me goat, I'll chew. But that's something you do. So it's about managing outbreaks, and this occur at all levels. So if you look at the surveillance data we have in Ghana, it's from community up. So the community, we have what we call the CBS volunteers. So these are persons in the community who have been given some kind of orientation to suspect epidemic conditions. So if they see somebody with yellow eyes, they say that yellow fever. So go and report. So then it's up to the next level to go and verify. If they see something from this rash, say mpox, go and report for them to verify. If somebody who cannot walk, polio, go and report. So that's the system that we have, and then we use it mainly when to address polio and then guinea worm. Because normally, when you have the hard-to-reach areas, the formal health systems are not functional. So you need to depend on the informal system, where there's a lot of social cohesion. And that's the way our surveillance level. So it works from community up to the national level. So these are some of the activities that we do when there's an outbreak. So there's communication across the structures. Normally we try to come out with an alert to make sure that everybody needs to be sensitized with the condition. Then we activate response teams. So if it's a very small district, we have at least 3 people who must be involved: a clinician, an epidemiologist, who normally disease control officer, and a lab guy. These are the basic people that should be involved when there's an outbreak. So based on the initial assessment, we need to now involve the region or even the national. So that's the structure that we use. And then you need to convey emergency management committee meetings. It may involve logistics, money, and proper coordination. So we have the risk communication. Then you have to mobilize a lot of resources, and then the implementation of prevention and control measures, and then training, and then the sit reps, and then in some cases you may need to do reactive vaccines campaign. This is very important for a reason. 2015, we had this outbreak in Borno region, at that time Borno region. So it was meningitis. Borno region is not in the meningitis belt. So typically, you don't expect to have many cases of meningitis. They start getting strep pneumo. So we went in and I realized that Tyne has strep pneumo, Wenchi has diphtheria. So you have a kind of a multiple pathogen. And that's why I'm saying that, you see, if you are not sure of the pathogen, you cannot be sure of the response. Because strep pneumo, you don't give mass vaccination. When it's Neisseria, can give mass vaccination. But even Neisseria, what is the serogroup? Is it A? Is it C? Is it W? Is it X? Or is it Y? So that's how the lab is supreme for effective response. So I'm now coming to my question. So to me, Noguchi is there to help the country confirm. Because with that confirmation, I'm not sure you are clear in your mind. Jon Snow did something, but he tried to make something. But we need to be sure the pathogen. And for Ghana, the center for confirmation is Noguchi. And I normally, when we see the results come from Noguchi, nobody will come and ask any questions. So let's. Yes, because if you are not careful, go and see from here, then they say, I'm not quite quiet then. So Noguchi is also helping in the sharing of logistics and equipment, and I think that I'm not seeing director. I mean, so we work together, and then we build capacity of our staff. So that's how come now our reference lab is now also able to do mpox. Yes. So Noguchi doesn't want to do all the work. So at times I don't call COVID money anymore. Which is good. And then we do a lot of collaborative research. I remember when we did the SATREFs, we were trying to find out the causes of diarrhea in Ghana, apart from let's say water virus or cholera. And it was a very good research. So now let me go into details what we have done together. So now I picked a few areas. And now let's see. So we have the National Polio Lab. Let me say that I picked areas that causes outbreaks. Because if you want to look at all, we'll sleep here. But I want to go home. So for polio, you have two kinds of surveillance. You have the human surveillance, what they call the AFP. You have the environmental. But all confirmation is done in Noguchi. So the AFP surveillance started in Ghana in 1996. And then the polio lab has been the main base for the surveillance system. So the first two wild polio viruses were confirmed in Noguchi in 1995. And then a lot of staff have been trained either in Noguchi or here. And they also trained on measles, yellow fever. And then in the initial stages, they had to do a lot of training in EpiInfo. I think now we do Stata or R. So these are some of the circulatory wild polio viruses that were found in Ghana in 1995 to 1999. So you can see that it's kind of scattered, but mainly in the south. That was the early stages, and now the early ones was more of the north. So these are some of the pathogens, wild polio viruses that we have had. But I think that the last wild polio virus in Ghana was 2003, 2008. Yes, in Yendi, 2008. So we have had a few also imported wild polio viruses in Ghana, so 2003 and 2008. And then a number of the different genotypes of wild polio in Ghana has been detected. So clearly polio, you have the type 1, 2, 3. And all of this has been, and I know that I don't know where it's Africa, but Noguchi is the center of excellence for polio. Yes, so if we want to talk about polio confirmation, you come to Noguchi. Oh. So I remember speaking to Prof. Odum about this work done. The idea was that we have been doing a lot of vaccination over the period, but what kind of immunogenicity has been generated over the period? So this work was done, and clearly it gives an idea that a lot of antibodies has been built in the population over the period. And it's telling me that even now, it thinks that you need to go ahead to do another set of cell prevalence study to see that years after the switch, what has been the population effect. So I think that's something that since Profama is here, NITAG will look at it. And then one of the things that if you're talking about polio eradication, you need to look beyond it in the human being to now look at it in the soil, in the environment. So that's how come we started doing the environmental surveillance. So if you look at the current polio that we've had in the country, it's mainly in the environment. And even this year, we had this outbreak that we are managing. At times, when I see Odum's email, I don't want to read it. Because if you are fine, then you give you problem. So they started with that in country, and it's about mapping some sites and then picking the sewage, and then try to find out whether they can find the pathogen in. And that has been one sure way to tell us that we are on the way to polio eradication. So they started in Accra, and as I speak now, there are about 6 regions involved and about 12 sites who take samples on a monthly basis. So, and this has helped us establish some outbreaks. I think the first one was 2019, and then I think 2022, and then this year we had this outbreak also in Eastern region. So these have been some of the effects of the polio lab. It's actually enhanced our polio surveillance. Now as I speak, there's a team in Koforidua trying to review our performance. They've also characterized what polio circulation in the country and determine the different circulatory genotypes in the country and help determine the polio antibody levels prior to the switch. You know, initially we used to have the triple, and now it's the bivalent. They also piloted and established a rollout of environmental surveillance to complement the AFP and detected the first circulatory vaccine-derived poliovirus in the country. That was in 2019. So the results have actually informed polio immunization for children under 5 in the country. So this has been the effect of the polio lab. Now let me talk about this VHF. I think this is at times a killer in the country. VHFs causes a different ballgame. I remember 2008, I went for a meeting in Kuala Lumpur, and people say, Ghana, you don't have disease there. Because people are doing wild things and be small pathogens. So the issue is that, are we looking for them? That's first one. 2, you have the capacity to confirm. So that's the one that gives you an idea of your health security. First, your surveillance system. 2, your ability to confirm. Because some time ago, I was called to go and see a case in Cocoa Clinic, which was like Mpox. I'm talking to Bonnie here. So I say, hey, for Bonnie, they say something like Mpox. The other time it was monkeypox. But we don't have the capacity to confirm Mpox at that time. So that case slided. We could not confirm Mpox at that time. Because at that time we didn't have the reagents. So it is not that Mpox just came in 2022. That's the first time we have confirmed Mpox in the country. Because as I said, it's about detecting it, it's about confirming it. So if you do not look, you do not find. And I think it's very important for us as a country. So the idea is that our VHFs in the country, and I think that's how come me and for Bonnie became friends. Yes, so I think he was looking for something. So I think that they initially to look at the proxy, and they wanted to use the viral hepatitis as a proxy to look for the VHFs. So I think that's how come they started doing this work. And what they found was, I think the focus was in the northern part of Ghana. And let's see what they found. Yes, so they took 300 specimens, and then they tried to look for Ebola, Marburg, Lassa, yellow fever, dengue, Rift Valley, chikungunya. But there was a differential diagnosis of hepatitis, so that was the proxy. And then what they found was that there was a possibility of circulatory Lassa, and then dengue, and then chikungunya. So I'm sure we were getting something. There's something there. But at that time, the evidence is not very much there. So let's see going forward. So this is what they communicated, and they did a write-up. So then they also went ahead to do a lot of vector studies. And what they wanted to focus on was, around us, Lassa is very common. Lassa fever, Sierra Leone, Liberia, Nigeria, Ghana, no Lassa. Why? Yeah, at times you need to ask yourself why. Because the characteristics are very similar. So why are you not getting this? Is that you are not looking, or you're not able to confirm? So keep on looking. So the vector is there, is the mastomys. And then if you look at this, so still, let me move for this one. So if you look at what they concluded was that they realized that the rodent mastomys is there. And what they concluded was that there's a risk of Lassa in Ghana because they were able to demonstrate the mastomys. But then there was no clinical basis for Lassa being in the country. So you have the mastomys, but you could not ascertain that you have the Lassa in the country. But I think they keep on looking for it until they found it. So this is the first Lassa, and this was 2011. That's I was in Ashanti region. So one thing I've been wondering is that why are we getting solitary cases? Just one case. And then we had one case, so it was 2 areas, or in we had one case, and after a few months we had another case, solitary. Is it that we were able to detect early that we could not have close contacts, that they did not get it together? Because normally solitary conditions are not common. Yes, because it's about contact. So, but then they found Lassa. So the lab they tried to rule out, because at that time it was acute febrile illness with sudden death. So they need to be bleeding. So they need to find out what it was. So they need to rule out. So they did Marburg, EBD, West Nile, dengue, and then until they got the Lassa. So they confirmed Lassa, and then it was managed in the bush. Let me tell you about this one. You know, it was like the mastomys is like a rat, and it's difficult to communicate properly. So we say exekusi. So I remember when we went to this village one day, so we were the community. Then there's a drunkard. The morning time, he came some cutlass. Say, started kusi, and then bring the cutlass. Because we are communicating that it is kusi, he doesn't want to hear about it. So at times, risk communication is very important in outbreak management. And then, so the first cases of Lassa was reported in Ghana and in Zaba, the rural community, and then it confirmed the circulation of arena viruses. And then around that same time, we have these imported cases also from people on peacekeeping in Liberia. They brought into Ghana. I think one died. So it gave an idea that clearly Lassa is not very unusual in Ghana. So these were some of the write-ups that came. So this one, so that's my name. But because I didn't write, I should have been here. There are times Kubiboni is writing, then they put me in between number 14. If I don't bring a sample, you can't be number 1, no. So make sure I'm number 2 or listen. Okay, so those are the issues. So now we have Lassa. Now the next one is that we have dengue. So there was also another journey. So they started looking about this dengue, and then they look at the samples from EBD and try to ascertain whether they could find dengue in. So here they found this dengue IgM positives. So the idea was that dengue a bit was in country, and so this was the antigen detection, and clearly they also try to ascertain whether we have chikungunya in the country. So they pick samples and look for the other pathogens. Then in 2021, we have this very big outbreak, and as I said, it's very common in savannah region, where you have this nomads coming. When they come with their cattle, they come in as a very susceptible population, they get bitten, and then the outbreak happens. So normally I tell my staff that when you are doing vaccination, don't be enthused about the global coverage. Be enthused with the details. Because if you get 100%, the idea is what is your denominator? Have you covered all the sub-districts? Have you covered all the communities? So clearly tells you that there are certain communities in Ghana that are still not vaccinated. And yet our vaccine coverages will be like 100%. In some cases even 120%. Yeah, it happens in the northern region. You know, we have a challenge about denominator. So if you use the administrative coverages, you may have a challenge. So in 2021, we had this a bit large of an outbreak that even extended to the year 2022 with a high case fatality of 17%. So this one is on your work. So this is some of the this is a molecular characterization that was done for the outbreak in 2021-2022. And then we went on to look at the Marburg that we had in 2022. And let me say that Ghana was praised for this response. And normally, you know, the global world, most people will always be buying their tickets that something has happened in Ghana. Let's prepare and go. Before they realize we finished. The outbreak has ended. So I believe in containment as source. So it's about early detection. If you do not detect early, then you make sure that at that time everybody will come around you. So that's what normally I tell my staff. If you don't want your office to be flooded by V8s and helicopters or whatever, detect early. Then you can think about yourself and sleep. So that's what happened. So this outbreak was brief. It was more of a closed outbreak. The case, the father, and then the baby. Very close outbreak. And we struggled to get a link. But clearly, you could say that it was a very close outbreak. And they were able to do the very massive contact tracing, and then we had very little spread. So this one, they did the sequencing, and clearly, this is one case that they sent a sample to Asiedu Pasteur. You know, originally there were 4 cases, but later one it came as 3. Because you see, looking at the clinical history, second case could not be a case. But what was good was that it was the second case that brought the suspicion. You understand? So finally, we realized that the second case was not a case. It became as a 3 cases. So this is also a write-up. And I'm sure on this one you are number 1. I'm not even inside. So let's go to the Mpox in Ghana. So finally, we had Mpox in 2022. And this one, that's the time that we have confirmation in Noguchi and our reference lab. So in total, we had 120 cases in 2022. But then Noguchi had about 62, and reference lab did the rest. So it's good that Noguchi is building capacity across the country, which is good. It's a good plus. Let's start for Noguchi. So this is the sequencing that has been done, and I think that we can also do sequencing in our reference lab. Hey, the thing is finished. It's not going. So I'm getting. I'm getting somehow close to my presentation. Go on. Okay. So that's then 2023. We had this Lassa outbreak. One thing that brought to bear about this outbreak was a very poor IPC in Ghana. So this was a case that was suspected in Kolebu, and yet a lot of health workers were affected. So it brings to bear the challenge we have. If it was happening in the district, or it's not an issue. But if it gets to Kolebu, it's supposed to be the pinnacle of healthcare, and people are getting infected, then it's an issue. So IPC is actually a challenge in Ghana that we need to look at. Thankfully, the fatality was very low. But I think that is one concern that we need to look at it. So maybe as we work in a lab, let's not lose our guard. There are health workers at times, I don't know whether they want to see the diagnosis on their forehead before they become conscious. But then our IPC is not very good. So we had this outbreak, but it was mainly concentrated in Greater Accra. At that time, when there's a high index of suspicion, others also look for it. So we had this several cases in Central Region. I remember going for Bonnie, but it came as negative. So the outbreak, the big one, was mainly in Greater Accra. And then we have this dengue. And the idea was that you go for meetings and people are asking, do you have dengue in Ghana? I say, I'm not sure. The evidence was not there. Though there are pockets, but you don't have the quantity, the magnitude. So let's see what happened in 2024. 2024, something happened in 2 regions. So you have a community that has people reporting with fever. And I'll end on something. There's a fever. In Ghana, every fever is malaria. So they force malaria on you. But at times you don't blame them. My boss has been saying it. If you say you are a doctor or a physician assistant and you're in the community, the mother has brought a child 39 degrees Celsius. You do your RDT. It's negative. So what are you going to do? You still have to give something. So either you are giving antibiotics to cause AMR, or you are forcing yourself to treat for malaria. Because you don't have the point of care testing. You don't have any differentials. Is it RSV? You don't know. So that has been the challenge. So they were seeing this fever, and they say it's malaria. But then the other issue was that there was also other cardinal signs which were ignoring. There were a lot of bites. But then they were forcing themselves to treat malaria. And at that time, we didn't have even the RDTs. So they just treated as clinical malaria until they brought it to Accra and then we sent it to Noguchi and it became as dengue. Around that same time, you realize there were contiguous districts. So it was like the eastern and then central. So we had the same kind of districts. So we realized that the vector was just moving across them. So there's a map which I don't have here. You would have seen that it's a contiguous district. They are all affected. The idea is that why did it happen at that time? I don't know whether the entomologists will answer. But then we are not clear. People are saying that it's some dark Galamsey pits or whatever. But then why that massive outbreak at that point in time? That's an issue that you may need to answer. So I know Prof. Dazi and the group are trying to find meaning to it, but it's something which is outstanding. So we are going to about our last set of conditions. So it's about the respiratory pathogen surveillance in Ghana. So this has been on for almost like 20 years. So we have the influenza surveillance. That is that Gucci voice with the AMRO, GHS, WHO, CDC. So we actually have a center in Ghana. That's the National Influenza Center, and we have sentinel surveillance going on in country. And one thing that I can say is that even when our routine surveillance is struggling, they have money. It's always working. So because they have a way of motivating the staff to send the samples. One challenge we have in Ghana is that we don't have EMR funding for public health. Yes. So at times, that hasn't come in. When she comes in, it's worrying me. I say, you also give me professors. there's no EMR funding for public health. It's a big challenge. I remember I made a presentation last year, and it was on funding public health agencies. But then the issue was funding public health. It's a challenge. So the issue is that the funding to move the samples becomes a challenge. So some of them, they have to budget. And then some of them we have to carry with VIP or what have you. So it becomes a challenge. So, but when it comes to the influenza surveillance system, they have some money. Every time they give them money. So that one normally will bring the samples. I'm saying the truth. But it's good. It's like when you have assured funding, you can have assured sample transport. And now we are working with Global Fund to have a system of a structured sample referral system. So it's a challenge. So you are not the issue. We are talking about solutions. Bold solutions. So we have that system in place. And now as I speak, we have the 10 old regions started, but the concentration was in Greater Accra. And but now let me add on that. Clearly, that surveillance system was set up to monitor trends in mobility and mortality of respiratory pathogens in Ghana. I think that the big thing was when we had the Kumaka outbreak. Yes, that was the time that we had this outbreak. And I still had, I'm not sure whether H1N1 can kill 4 people. Can it kill 4 people? I don't know. But then it was an issue. I remember that time. You know, Black Sheriff. You know he was there. Yes, 2017. That I went there to stay there with the people. So identify locally circulating influenza strains, monitor the health of people exposed to infected animals, and to report emerging and re-emerging infections. So this is the objective. Oh. So I have just a few slides. Then there's no battery. Hey, can't go to heaven like that, though. So as we speak now, we have all the 16 regions having the influenza surveillance going on, and we have I think over 30. It's not working. Okay, so these are the sentinel sites we have in Ghana. So all the 16 regions are actually doing influenza surveillance in their sentinel sites. And we have 36 sites across the country. So for Ghana, we are doing EIDSR. And our tool of choice is the SOMAS. So we've tried to make sure that all the sentinel sites are enrolled into SOMAS. And we also expanded the scope. You know, Ghana used to be 10 regions, and then it became 16. I remember 2010, I traveled. I came back and said, Ghana has become lower between income countries. Within 3 months. So likewise, Ghana, we have increased from 10 to 16. So we have expanded our sentinel sites. And then we also have the guidelines that has been distributed. And then WHO actually recognizes our center since 2010. We share a lot of viruses with WHO, collaboration centers, London, US CDC. And then we submit data to the FluNet. And we've actually integrated SARS-CoV-2 into IL. I think this is one of the big things that Ghana is doing. The integration of SARS-CoV-2 into the ILI surveillance. There's a lot of collaboration going on between VSD and then GHS and then Noguchi. So this is a slide that gives an idea of the integration of SARS-CoV-2 and then the flu in Ghana. So I remember somewhere last year, there was a time that everybody was coughing. And was wondering what it was. But then the only sure evidence was this kind of surveillance system that we have. That could actually tell us that clearly we have the SARS-CoV-2. Because people do not routinely now go to the hospital. Yes, and the priority to put to our full stop, the money is finished. So at times, we are not very sure whether you have SARS-CoV-2. But what the evidence that SARS-CoV-2 is still in the country is when we have this integrated surveillance system going. And the Noguchi has supported the country for the novel influenza since 2009. Then there was this big outbreak that we've had. It's very common. Normally, Eastern region tends to have a lot of flu outbreaks. I don't know what's the issue. But then almost all the Dadaba schools in Eastern region and then Dodowa, every time they are getting outbreaks. Yes, so program look. So then surveillance system has served as an early warning signal, and the system has actually identified and alerted GHS for appropriate public health responses. And then the initial diagnosis and testing for SARS-CoV-2 has actually worked through this surveillance system. So this is a very big finding that has occurred in Ghana. This was the first human case of avian influenza in Ghana. The H9N2. I mean, we are still struggling how that case came about. Yes, you are not very certain how that child got the infection, but that is an issue that maybe we need to still probe further. How we got this infection? But then it's a global finding that we need to better explore. But we are grateful that Noguchi confirmed that it went outside and everybody confirmed that we have this H9N2 in Ghana. So my outlook is that other public health laboratories have developed capacity to support confirmation of outbreaks. And this is true, which is a big plus for Noguchi. So now it's not only Noguchi. I remember when we had the COVID, it was Noguchi KCCR reference lab, which is a good plus. Then this one, streamline linkage of health surveillance system and laboratories, especially the private sector. This is a big issue. What happened is that there are a lot of private facilities who do not know that there's something called a surveillance system in the country. So when they get a case, they see it as a clinical condition. So I see this, I come in, I have fever, headache, doctor thinks malaria, go to a lab. This one, they also think and say, go to Noguchi. And some, they don't know that we have even a case-based form to be filled that should get the right kind of variables. So those samples are sent to Noguchi. In some instances, for Bonnie Wutu will not stop them, they do the test. The challenge is that there is no contact identification or tracing. It will keep very challenging when you had the outbreak, the COVID. There were instances even became more profound at the early stages of the COVID-19 where the private people came in. Where people didn't want to make their friends known. Not some because the time that the COVID was around friends and relatives. Friends and families. Yes. Because they came from UK, have their parties, and said about it among themselves. And then they themselves have their lab. So they will do it and no share with the surveillance system. So our data does not capture them. So I remember at that time, one big guy called me, Franklin, are you sure you are getting all the data? Because the data is not showing. And he knows the people who are infected. And some of them, if you get them, they will give you wrong address. So it's a very big challenge in Ghana to address future outbreaks. You don't see how, apparently, let me tell you, the early stages, we didn't want to involve the private sectors, private labs, because of what I'm talking about. Because they have a different motive or motivation for testing. And it's not for public health purposes. So it's a challenge that, though it was good to improve an expansion, it had its own public health issues. And most of them to also go and sit on Twitter or Facebook, and also insult us that we are not showing the data. And they have done the test among their friends. And they will not share the data with anybody. So this is a big challenge for public health. Then the other issue is assure and sustain availability of lab reagents, including point of care. And as I talked about, if you're able to help find some differential diagnosis, you need to have an array of point of care testing. What pathogens are causing acute febrile illnesses in the country? If it's not malaria, what? If it's a viral condition, can we confirm it? Can we diagnose? Can we suspect? So the people will continue to give you, I mean, when you call it malaria, rule out upper respiratory tract infection. They'll give some small antibiotic, give some small anti-malaria. So that has been the challenge. So I think that I'm looking at Prof. So these are things. Yes, more especially when you are down there under pressure. And then I think the last thing is to strengthen the coordination of laboratory network, purposely for quality assurance. Because lab is the basis. If you are not sure of your lab diagnosis, it will actually defeat health security in the country. So my last slide is that I'm concluding that public health emergencies, including disease outbreaks, remain threat to Ghana. Ghana has seen several disease outbreaks, including ones that were previously not recorded. Surveillance for priority public health diseases and events essential in preventing major outbreaks. Public health emergency structures, the one that not this one, including designated labs, are essential in ensuring appropriate response. And then my last thing is that Noguchi has been a backbone for the timely detection of outbreaks in Ghana in providing leadership in emergency response. So I want to thank all of these people for my presentation. Thank you very much.
A warm round of applause, please. Thank you very much, Dr. Asiedu-Bekoe, Dr. Franklin Asiedu-Bekoe, for that. We have a few minutes for questions. We'll take multiple rounds of questions with Madam Chair's kind permission. 3 questions for each round. So if you have a question, kindly raise your hand. The microphone will be brought to you. Questions, comments?
Thank you very much. Well, a comment and then maybe a question. I've been around really long, seen more or less some of the early beginnings of Noguchi. I would have been here, working here, if it hadn't been that Professor Marinadi chose to keep me at biochemistry. And so I want to really commend colleagues here for all that they have done over the years. And I believe we want to also commend the Japanese government for how they began with us and have not left us and have ensured that our work has been sustained. And I'm also thankful to Dr. Franklin Asiedu-Bekoe. For me, I've learned a lot, so I'm very thankful. It's quite clear that you've been working with the politicians, the government for that matter. To what extent do you think that the government understand, or the politicians understand, the role of research in the management of these diseases of public health importance? For me, I think it's when it comes to those things that will enable them to be voted for, that they get interested. I don't know what it will take to actually motivate them to get interested. Will it be that some of us would have to join and become politicians too, or what? You know, I really wonder. I know you have mentioned a few. Let me just leave this. I had a few others.
Thank you very much, and I think I'll start by appreciating Noguchi for putting these lectures together. This is my first time being here, and I've really been to a revision class. Dr. Asiedu-Bekoe, thank you very much. I have to add a Franklin. Dr. Franklin Asiedu-Bekoe, thank you very much. I have 2 points to make. The presentation was great. I was just wondering whether we wouldn't have benefited from a slide that tells us the supports that has come through to Noguchi for all the effort. I know it has come, but so that we would also know that you are giving us support too. And some of the challenges that we are grappling with to be able to strengthen Noguchi to do even more in the coming years. And then I was wondering, with the flu surveillance, are we at a point in the country where we need to start taking flu shots, and for which ones? Thank you very much.
Okay. Thank you very much, Dr. Franklin Asiedu-Bekoe, for this insightful and eye-opening lecture. From your one major point I got from your presentation was that all this is heavily dependent on detection, and the starting point is always the clinician. You've talked about the challenges and so on. One thing I was wondering is there a system in place such that it will reduce the subjectivity of the clinician, such that they can have some resources to have other differentials other than what we have currently, where every fever is malaria? That's one. Two, relating the detection to reporting, is there also a system in place that would, improve that, such that people's biases or all that won't interfere with that, so that if a case is detected, it is reported up to the appropriate levels? And then the final one is, how would we intend to prevent panic and have due, accurate reportage of such cases? How is it going to be handled? What system as well do we have in place to handle such communication? Because as you have also alluded in parts of your presentation, sometimes reportage can cause a lot of issues. So those are the 3 questions I have. Thank you very much.
Yes, thank you very much. So let me start from the last one. I think yesterday the Vice President launched some is it a tool or a reporting system which we have started using in our office. And it's called the LIMS. The LIMS has 2 components. It has the electronic medical records part and has the biosurveillance part or the surveillance part. What it does is that it's like automated, so it does not depend on the individual. So there are 2 tabs. One is the surveillance data. So maybe as somebody comes to the consulting room and then I diagnose cholera, it will come on my dashboard that I'm seeing cholera in, let's say, Odo. So that's one. But then we have tried to enhance the sensitivity by now making it syndromic. So what is happening is that if the clinician see fever and jaundice, the clinician can say it's hepatitis. But for some purposes, we are saying cholera. We are saying yellow fever. So for us, we will see it as yellow fever and investigate. If you see diarrhea with dehydration, the clinician will say gastroenteritis, but we will say cholera and look for it. So we are moving away the subjectivity of the clinician and making sure that the system is very sensitive and we can look for it. So that is the way we're going to go to make sure that the clinician is not the one determining what you need to do for. The other issue is typical clinicians are not bothered about surveillance. They want to make a diagnosis and go home. So the idea is, how do we sensitize them to get orientation? And I remember I think until I finished medical school, I didn't even remember what I learned in school, in community health program. So one of the things that I think that maybe I don't know how we can make whether community or for public health interesting in the undergrad, but then it's a challenge. So most people don't find public health interesting. And then when they come out, there's something called clinician sensitization. The guy going to sensitize them is a disease control officer. And how can that guy go and sensitize the professor? So it's a challenge that we have found, that we are saying that like. So we are saying that the deputy directors clinical care and the deputy directors public health should now go and sensitize the doctors so that they value what is it that they are in. Otherwise, we will have less suspicion of epidemic conditions and they will detect early. The other issue we are looking at is that, you see, detection is not wholly dependent on the clinician. We also have what we call the records review. So records will be reviewed, and based on the aggregation, can give you an idea of a possible outbreak. So those are the things that we are hoping to do that will improve on the sensitivity of the surveillance system. The flu shots, our surveillance system that we're running now is not about bedding. So I think that there's this thinking about we trying to ascertain the burden and which are the at-risk groups to give us the basis to say that we are going for flu shots. But I think that you can look at the possible at-risk groups as the elderly, the children, and the health workers. And I know there's some thinking around starting something like that in Ghana. But now for the surveillance that we're running, we're trying to ascertain the genotypes. It's not about the burden. So I think that we need to be able to generate the evidence that, but as I said, you know, there are some pockets in Ghana that have recurrent outbreaks. So either we try and say that when you belong to this environment, then maybe you can say that let's do a flu shot. But as I said, like the mpox vaccination, we are trying to ascertain which group should we give the vaccine to. Who are the at-risk groups? Whereby you don't have the empirical evidence to say that these are the people who are getting the infection in the country. But you can make a guesstimate that these are the possible at-risk groups, but the data now does not support it. So for me to say that we should go and block, maybe Prof. AMA, NITAG, but that depends on data. But we don't have the data now. So maybe, yes, so we'll see how we can generate. But I think that is some thinking among some group about trying to generate the data of flu in some age groups that we can target. Then you see, the government has made some, I'll say, inroads, but they have a different way they approach their things. You see, when COVID started, Ghana had only 11 treatment beds. No, it was 12. 7 was in Tema, and 5 in Ridge. The whole country. We are going to start COVID with 12 beds. So clearly, if you don't on the government that you don't have the capacity. So if you look at the World Bank support, it was mainly addressed to put up treatment centers. So now, if we're talking about beds for managing cases, I think they have it. They also dawned on them that we don't even have standardized hospitals in the country. So that's how they came out with this Agenda 111. But I think that the public health part is a challenge. Because you see, public health is difficult to explain. Even my mother asked me that, Kofi, I don't know doctor way. It's difficult. Because they know doctor. But public health, what is that? And public health does not win votes. They want tangibles. If you are saying NEC has done this, what are they going to say? They say the coverage, measles coverage has moved from 89 to 90. Who understand? So I think that it boils down to how do we communicate to them. So I think that is an issue for all of us to see how do we communicate for a politician to appreciate the benefit of public health, because it's not very, very tangible, and it's a challenge. And I think that we all need to think through it. How do we make public health interesting? One thing I would say is that COVID-19 has made Ghana Health Service very visible. Because I'm sure before COVID-19, people even know there's something called Ghana Health Service. So maybe, we are not saying maybe, but maybe when more outbreaks come, then it will bring the visibility of public health. So I think that's an issue. Nobody's fighting for the wrong things, but I think we need to think through, as practitioners, how do you make public health visible to demand or attract support? That's one thing I would have to say. But then the other issue is what the ministry has done for the Gucci. I think it's a lot. We can't list all. I should list them. Okay, I'll give the answer. But you know, one thing that I think which is good is the collaboration. Let's clap for ourselves. But then I know that it's on the table of the minister now. That he calls me that, Franklin, we need to get something from the Gucci. Yes, so it's on the table. But how to come is the issue. But I know that once in a while something comes. But as I said, because it has a general deficit in funding for public health, it affects everybody. But I know it's on the table. Thank you very much. Asiedu-Bekoe. No, you see, what is happening is that I'll get the details and share, because most of the answers will come from the ministry. Do you understand? So I'm sure they have more information which I don't have. So So that's what I'm saying for now. Is Asiedu-Bekoe talking, not Frank or Franklin.
Thank you. Frank, it's not a question, it's a comment. When you ask, how do you explain public health to people? Politicians only, and a lot of policy people think about the economics of it, the cost of interventions and things like that. I think we should not only look at the information regarding how many A has been found, how many B has been found and things, but then we should also look at it in terms of what is the cost averted to the Ghanaian populace. And so when they begin to understand that, or if you put in 5 cities, you save 200 cities, they say, that's the business I want to do. And I think it's a very good way of pushing politicians and policy folks to really understand and support public health. The other thing that you said, I'm happy you said that there's something on the table for us. Some of us in Ubukti here have placed orders for reagents since April, and we are still waiting for them. Just because, not because you don't have them, you have the money. It's because there's something like what? Procurement and tax waivers. I mean, we're going to use it to improve the, the health of Ghanaians, but then we still have to wait for over 6-7 months. Some of the regions will go back, and then we have to go back again. So these are some of the things that can be done to facilitate, and bring us much closer. Thank you.
Thank you very much, Franklin. This has been a very interesting talk. You made mention of the fact that you have a challenge in terms of getting the private practitioners to be in the system. And I wanted to find out what you've been able to do about it, because if we're not careful, that becomes a huge gap which will always affect the work that you do. Thank you.
Thank you so much, Doctor, for the excellent presentation. I had a question about the circulating vaccine-derived polio, and if what it is what the name says, and if it is, then how does that impact people's hesitancies around vaccines, and what can people like us then say to kind of lower the fears around vaccines?
Thank you very much, Doctor, for your presentation. I'm from Liberia, but I heard something that interests me. That is concerning the ECMO at the time that brought an illness from Liberia to Ghana. I think it is because of the politician that took ECMO to Liberia. And then the ECMO brought illness from Liberia to Ghana. What plan do you have in place to have a regional surveillance system in place? Like, for example, the security people have the Interpol. Do you have such a system or a plan in place to be able to save the region from such?
Okay, so thank you very much. So, for Farmer, thank you very much. So, one thing that I need to state is that there's a lot of investment case which is being developed for a number of the disease conditions. I know NTDs have put something together. They work together with UNDP, and TB is trying to get something like that. So, and at times, because I'm the target public health, it's like we need to get investment case for everybody. So they need to have a very jointed investment case for public health. So it's something that I think I've discussed with WHO, that how do we generate that kind of evidence that would get the politician to see. So it's an issue that we are discussing, but some disease specific ones are available that we can work on. The private sector, yeah, Prof. So one of the things that we're doing is, first and foremost, involvement of the private sector in our trainings. Because what challenge is that even when we go to a district and they are doing trainings, at times they don't involve the private sector. They are very comfortable with themselves. So the private sector is not part of the training. Private sector has also another challenge about the high attrition. Most of the doctors there are doing locum. So the person you train today, you go here tomorrow, is not there. So it's a big challenge for us. But what we are doing is that, at least for the doctors in general, I know we try to do regular Zoom meetings. Just a few months ago, we did one for over 2,000 doctors on mpox. I know somewhere earlier this year we did one for surveillance in general. So we want to see how best we can get clinicians in general to be part of it. But the private sector is about how HEFRA can ensure that reporting is part of their way of doing things. Because if they are not reporting, and yet you are okaying them to work, we will not get. So it's about working together with HEFRA to ensure that the private sector or facilities conform to the setup. I think that's one way that we hope that we can improve on their conformity to the way surveillance is run in the country, whilst we try to also engage them to train their persons. And in some instances, we've been second some of our staff to their private facilities to help them do their work, especially when it comes to records review, because some of them say they don't have time to review their records. So our persons go there to review records. So it's one way that we are hoping to improve. But Prof, I'll talk to you. My man. Yes, and let me also say that the teaching hospitals, there's also another cohort. You know. Yes, so there are instances that the professors say that what you are doing is not evidence-based. So you can see that at times, I remember those days, what the people are using in Kolebu is not what is in the guideline. So one of the things that we're going to do is engagement. I remember I was talking to Prof. Binka, how to help engage the teaching hospitals. So that when we say a program, like the way Prof. Chair say malaria program, it is not for Ghana Health Service. It is Ghana program. So that when you are in a country called Ghana, and let's say you have malaria, this is the way you are treated. And I think that is very important for us. So it's an issue that we are trying to see. And it even helps our data set. Now malaria, I try to talk about malaria elimination. Is the data whole? Does it include the private? Does it include the teaching hospitals? So that's one thing that we have taken up ourselves, that we need to get all the data. We need to make sure we have conformity in terms of standards. So that's one thing that we want to do. About the regional surveillance system, we are trying to do something. The WHO is building regional groups with a set of competences that will support member states when there's a problem. So just last month, what they are saying is that each country should train 50 people, experts in several areas, in case management, in surveillance, risk communication, what have you. So, and they're also trying to look at logistics management, and I think they're going to do a sort of trainings, I think somewhere in November. So the idea is building regional capacity and block, so sub-regional and regional, so that these issues can be addressed. We think that when you talk about global health security, it's about security across all countries, not some and leaving some. The circulating vaccine-derived poliovirus. I think one of the things that we try to do is, at times when it comes to communication, it is not the wild polio, but then in some instances, about 1 in a million, you get the vaccine itself getting mutated, that now it causes the virus to cause paralysis itself. So it's a challenge, and it has to do with the type 2. So what we want to do is that instead of using the oral polio virus vaccine, we are now going to use the injectable or the inactivated, because it is the oral polio virus vaccine that is causing this circulatory viruses that can cause the paralysis. So Ghana, for example, we have tried to, now we've used, we have started with the IPV, which is a bit more expensive, but has less side effects than the oral polio vaccine. We are going to introduce the second dose of the IPV2, and I hope what to do is that hopefully we'll now go off all of the oral and go for the inactivated or the injectable, which has no side effects. One of the things that the oral polio also has a bit of advantages. When you take the vaccine itself and the people go and pass out the feces, that also go to immunize other children. So it has a lot of positive effects, just that it has this side effect of also causing the paralysis. So what you want to do is going forward, which is done in other developed countries, is that they don't give oral polio vaccine, they give the IPV. Thank you.
Yes, please. I have a few questions. I just two. Okay, so I was a bit alarmed with the infection of Kolebu staff with the Lassa. So just want to know, how often are they trained or educated on some of these things? Like, what is the training that is done for them, so that when it's not malaria and they would have to look out for other viruses or bacteria, how have they been trained so that they don't get themselves infected? And then the other one is about the fact that, are these viruses really emerging and re-emerging because we don't look out for them until there's an outbreak? Or are they just coming from other countries into our country? And could there be a way of detecting a plethora of viruses, a lot of them, and how economically viable is it for GHS to be able to say we'll have a lot of viruses that we look out for?
Okay, thank you very much. So, Madam Chair, I think this question is between GHS and Noguchi, because we suspect and bring it. So you should confirm. Yes, because we are not sure what they are. The only issue is that we have a clinical picture, which is not the norm, but it's up to the diagnosis to help make it. But whether it's emerging or re-emerging, you see, there's a lot of zoonotic conditions all over, and it has to do with a lot of factors. One, we are getting closer to the forest. If you look at the dengue that occurred, those places were supposed to be forest reserves, and then we are entering it, and we are getting closer to the monkeys, getting closer to the viruses that will infect you. So our way of working now is getting us closer to not the normal habitat for human beings, but habitat of the animals that we are going close to there. So when you get there, they will share their viruses with you. Then the other issue also has to do with now more transportation. So you can easily be sharing diseases online in the time past that will take so long a time to get to another destination. So those are globalization has also increased the risk of outbreaks. And typically a lot of them are zoonotic in nature. So they could be emerging and re-emerging, but the issue has to do with capacity to confirm. If you don't have capacity to confirm, you will say that they do not exist. At times I ask myself, do you have chikungunya in Ghana? Chikungunya, I don't know. It's only biology for Bonnie who can tell me. For me, I'll send a sample. If you say it does not exist, why am I saying it exists? So is the ability to diagnose, to confirm, who to give the full picture of pathogens in the country. And let me end by saying that the burden of disease is dependent on the kind of surveillance system that exists. If you have a very passive surveillance system, always waiting for people to come, you see a different breed than when you have a very active surveillance system. Because when you have a country that has hard-to-reach areas, that people may not even report and they may be dying, the idea is that what is killing them, particularly how to do with NTDs. Do you understand? So it's about the surveillance system that we have in the country and the sophistication of the lab systems that will get a true picture of disease burden in the country. Thank you very much.
Thank you very, very, very much. Let's acknowledge him with a big round of applause. We are quickly running out of time, so I'll hand over to the chairperson for her closing remarks.
Yeah, I know you all agree with me that it has been an interesting presentation by Dr. Franklin Asiedu-Bekoe. So let's put our hands together again for her. And be done quickly to contain the disease like they did with the Marburg. And it's very, very good that Noguchi played an important role. And Noguchi is doing more for the confirmation of pathogens. It's also good to hear that they are training staff of GHS, and with that, they've been able to set up their own reference labs to ease the kind of heavy burden that is brought to Noguchi when these diseases, these outbreaks come up. And then the need for the sharing of logistics. It's good that we also help them with some of our grants, but then they also do their best to bring us some of the things that we need to help them with the work. And then the training and the building capacity for the staff. So I would say that in total, Noguchi has been very, very influential in viral diseases research and viral diseases control. And then some of the things that he mentioned that I think I thought about, like I also wrote down, was the fact that we informed the decision on polio vaccination, which is very, very good. But then the one thing that I just want us to also take with us is the fact that he really reiterated the fact that there should be synergy between the public and the private institutions in disease control and elimination. Thank you very, very much.
Thank you so much, Prof. Chair. Please bear with me. I just have a couple of announcements and then we'll be out of here. So next week we are rounding off our 45th anniversary celebrations. I'm sure you've seen the banner and some of the posters that have been shared. Next week, Thursday, November 7th, we have a symposium that is going to speak to vaccines, global health, public health emergencies. And we have eminent national and international speakers. So that is something to look forward to. In addition to that, we have a panel discussion that involves 4 of our past directors of this institute, looking at where we have come from and where we intend to go. So that's also another thing to look forward to, all on November 7th, next week, Thursday. And I don't know whether this or the next one is the climax of the celebrations, but after the panel discussion, there's a debate on quite a very interesting topic. Normally, that would be the climax. But once we are done with the debate, then there is a cocktail to celebrate the 45th anniversary. So please mark the date so that you can be available throughout the day as we round up on our celebrations. The second announcement is that later this evening at 5:30 p.m., one of our own, Professor Regina Apiaopong, is giving her inaugural lecture as a fellow of the Ghana Academy of Arts and Sciences. It's at 5:30, and it's at the Ghana Academy building in the airport residential area. So as many as are able to support her in person, kindly do so. I believe that a link might be available and might be shared for those who are not able to. So thank you very much. Thank you very much. This brings us to the end of the last of our lecture series. I think there's an old African proverb that says that if you want to go quickly, go alone. But if you want to go far, go together. So I think that Noguchi and the Ghana Health Service will look for ways in building stronger collaboration so that we can go further together. So thank you very much, and I think this brings us to the end of today. So thank you very much, and enjoy the rest of your day. Thank you.